DX is proud to be supported by AMBOSS, a medical education platform with an expansive resource library and USMLE-style question bank. Hi, I'm Brianna. Welcome to 10 Clinical Minutes from Decoding DX. This is part 2 of our 2-part series on random EKG pearls. I previously had made this one video, but realized it was pretty long, so I decided to split it into 2. So make sure you go back and watch part 1 before watching this episode. We're still talking about P waves here, and I want you to take a second to look at this EKG, pause the video, and see if you can see anything that's particularly abnormal. Here's a little clue. Focus on lead 1. There's something very off here. What we're looking at is that the P waves are negative. Think about the electrophys. Lead 1 is on the far left side of the body. There should never be an instance where the P wave is appropriately negative according to lead 1. The atrial depolarization is always going to happen from the right side over to the left side of the heart in general. Even with cardiomyopathy and other abnormalities of the heart, you should never have depolarizing electricity going from the left side to the right side of the heart. That should not happen. So if you have negative P waves in lead 1, there's something off. What could cause this? Okay, so there's either something super, super common or super, super rare. There's not a whole lot of in between. When you're considering your differential, the first 3 things should always be limb lead reversal. What I mean by this is that the lead that's normally on the left arm is put on the left leg, and the left leg is put on the left arm. So that means that lead 1 and AVF are flipped. This is the previous example that we just saw. Almost always, if you have negative P waves in lead 1, there's a limb lead reversal. You can also look for a negative QRS that can clue you into the same thing because that should be flipped. Other clues include preserved precordial R wave progression. This is telling you that the heart is indeed oriented correctly in the chest because the more to the left you get, the more overall heart muscle that you're getting. So the more electrical signal that you're getting. Okay, well, let's say you check your leads and they are placed appropriately and you still get negative P waves in lead 1. This is where we get into the super rare things. One cause is dextroposition, which means that the heart is essentially being displaced to the right. This can be caused by lung hyperinflation and a few other things, but typically you're going to have a lot of other things going on if the patient's heart is displaced this severely. And the super, super rare one is dextrocardia. This is when the heart is actually flipped on the right side of the body. So this is an example of a patient with dextrocardia. You can see that similarly to the limb lead reversal, we have a negative P wave in QRS in leads 1 and AVL. But some other signs that there's something else really weird about this EKG is that you have progressively decreasing voltages in the precordial leads. If you think about that electrophysiology diagram, this does not make sense. As you move more laterally, you should get more of the heart's mass because the heart is on the left side of the chest. In this instance, the more lateral you get, the less electrical signal you're getting, and that should not happen in the normal position of the heart. Next up, we're going to talk about some bundle branch blocks. So in a normal left bundle branch block morphology, you're going to have some discordance. What I mean by that is that the QRS and the T wave are on opposite sides of that isoelectric line. So you have a negative QRS and a positive T wave. Let's say you have a patient with a known left bundle branch block, and you see this on an EKG. This is called inappropriate concordance, meaning that the QRS and the T wave are on the same side of the isoelectric line. Negative QRS, negative T wave, negative QRS, negative T wave. That is not normal in a left bundle branch block. Another inappropriate finding would be exaggerated discordance. Look at how extreme these amplitudes are. You have a super deep QRS and a really tall T wave on opposite sides of the isoelectric line. Both of these findings, inappropriate concordance and exaggerated discordance in the presence of a known bundle branch block, is really concerning for ischemia. We know that a new left bundle branch block is an equivalent of ST elevation for an MI. But again, if we have an existing known left bundle branch blocks and we've seen these findings, this is also concerning for ischemia. This brings us to the Scarboza criteria for an acute MI in the presence of a left bundle branch block. There's a lot of details to this as far as how much, what degree, what score you get, but the takeaway I want you to take from this is that a patient with a known left bundle branch block, if you see inappropriate concordance or exaggerated discordance, you need to be concerned about ischemia and start a workup for acute coronary syndrome. Alrighty, last abnormality that we're going to talk about are second degree AV blocks. This EKG is an example of a second degree Mobitz type 1 AV block. This is otherwise known as a Winky block. And this one in particular, I want you to note that there's a 5 to 4 or a 6 to 5 concordance of the AV block. So what those ratios mean is the number of P waves to the number of QRSs. So in this first one, we have 1, 2, 3, 4, 5 P waves, but 1, 2, 3, 4 QRSs. So that's the 5 to 4. Over here, we have a 6 to 5. We have 6 P waves and 5 QRSs. So you'll see oftentimes a 2 to 1 or a 3 to 2. That means P waves to QRS. In a second degree Mobitz type 1, the block is intranodal, meaning it's within the AV block. This is important to note because there will be a narrow QRS, meaning that the block is happening before it gets to the His-Purkinje fibers. The electricity is able to distribute appropriately and equally across the ventricles, so you still maintain that narrow QRS morphology. This is why the treatment is pretty much the same as a first degree block, because your pathology is within that AV node. And so you want to avoid AV nodal blocking agents to make the PR interval even longer. But in general, this is a pretty benign lesion and you can treat it conservatively. If, on the other hand, you see that you have a constant PR interval and then a dropped beat, this is a second degree Mobitz type 2. And this is really important to distinguish because the management for this is similar to a complete heart block. This often requires a pacemaker because it's much more unstable and it can progress to a third degree block. In a second degree Mobitz type 2, the block is actually infranodal, meaning that it's below the AV node. What you have here is a fixed bundle branch block on one side and an intermittent bundle branch block on the other side. So when the intermittent block is open, you get the P wave QRS, P wave QRS. But when that intermittent block is blocked, you get the dropped QRS. In this instance, in this beat, you essentially have a complete heart block for that time. But then it'll open back up again, and then you'll get the P wave QRS until it closes again. This also makes sense if you look at the QRS morphologies. Look closely here. Whereas with the type 1 block, we had a narrow QRS, here we have bundle branch block morphology. We have wide QRSs. So that makes sense. If the pathophysiology is bundle branch blocks, you're going to have a bundle branch block morphology on the EKG in most instances. Why this matters is because if we have a 2 to 1 block, we can't definitively call it a Mobitz type 1 or a type 2. This is really problematic because do we treat it as benign or do we need to put in a pacemaker? So in this instance, you can see the P waves here with the green arrows. It's a 2 to 1 block. We have P wave QRS, P wave block, P wave QRS, P wave block. So we can't look at the PR intervals to see if they're prolonging or not. So in this instance, we have to either rely on other clues of the QRS or try provoking the rhythm to show us which one it is, or even just watch long enough to see if it'll go into a different pattern like a 3 to 2 where we can look at that PR interval. But a big clue here is to look at the QRS complex. Because remember, if it's a narrow QRS complex, that's telling us that most likely the block is happening in the node because it's getting to the bundle of His and Purkinje fibers in time proportionally to cause that narrow QRS. So let's look at a different example. In this one, again, we look at our P waves. We have a 2 to 1 block, so we can't tell if that PR interval is lengthening or not. So we need to rely on the other clues or watch long enough to see if a different pattern will come out. But in this instance, we have a wide QRS with a bundle branch block pattern. So this makes us worry that this may be more likely a Mobitz type 2. In this instance, we're going to want to definitely consult cardiology. They will do things like electrophysiology studies to make sure what type of block is going on, and they may need to put in a pacemaker for this patient. Here's some sources. If you enjoyed this video or found it helpful, please like and subscribe. It really does help out our channel. If you have any questions or comments, please email us at info@decodingdx.com and check out our website, decodingdx.com, for past episodes, show notes, and to join our mailing list. Thank you so much, and we'll see you next time.